Welcome back to Two Nobody's, everyone. With Pastor Tyler here again. Hope you all had a great summer. Definitely needed a break, but I'm ready to go, and we're going to have some great episodes that we're going to be recording in the next few months. Back with an awesome guest. You know, one of my first interviews and recordings was done with Dr. Stuart McGill, a friend of mine. He was my master's mentor at the University of Waterloo. It was a fantastic conversation getting to know Stu. And, you know, Stu talks a lot about spiny things and the low back on many different podcasts, but to just have that sort of human-to-human conversation was something special. But I have his protege. I have this guy who is the master clinician for the company Backfitpro, is their lead instructor, Dr. Edward Cambridge. Ed and I crossed paths very in a short amount of time at the University of Waterloo. Never really had a chance to get to know him, but really looking forward to having him today. Ed, Dr. Edward Cambridge, thanks for joining us today on Two Nobodies. Looking forward to the chat today.
Rupesh, thanks for having me. It's humbled and honored anytime you get asked to do one of these interviews. And yeah, thanks for having me on.
That's awesome. Well, thanks for joining us again. You know, I was thinking about your role at Backfitpro, and I've been following. I mean, Stu is somebody I always follow, once I left the field and continue to follow that. And when I saw like sort of how Backfitpro continued to evolve, and I saw that you were getting involved, and all of a sudden you became their lead instructor, it made me think if like, and I don't think, did you study at the University of Waterloo? I know you did your Ph.D. there, but did you do some of your other degrees there at all?
Just my graduate work. So I started in the master's and fast tracked to the Ph.D., but none of my undergrad work. Okay,
so if you're an undergrad student at the University of Waterloo doing that kin program, if you take Stu's course, he's somebody everyone's just like looking up to, right? As like the guy you want to work with at some point. And to ever think that you could actually work side by side with him on a daily basis, you know, that's possible through a graduate degree. But I would imagine many of his grad students, I was one of them, you were one of them, many grad students wouldn't think that the journey would continue where you actually get to work with him on a day-to-day basis, let alone be a part of his company, and now have his full trust that you're one of his lead instructors. So it's like, it's amazing to see you as that person, you know, on that journey. And I don't think people understand that, you know, just again, Stu's like this, he has this kind of aura about him at the University of Waterloo, and especially in kin, and especially around the field that he you know, has been a master in. And so I feel like it's a high honor that you've been able to get that spot, but just obviously an incredible amount of work must have come your way from your end. And so I really want to hear more about that. But tell me about, like, you know, as you kind of got to work with Stu, and then once he's like, hey, Ed, you're my guy, I want you to be the lead instructor. What was all that like?
Yeah, well, that's a big bite to chew off of, and I share your awe of Stu. In fact, I had sort of a third-party experience with him. Two of his previous PhDs, Dr. Kim Ross and Dr. Dave Bresnik, were at the Chiropractic College teaching, and that's how I got introduced really to Stu. They always talked about their mentor and how much he did for them, and how much he meant to them and changed their careers. And so I already had this massive image of Stu before I ever met him or really knew who he was. So I can remember I had to go to the university, drive down from Toronto down the 401 to Waterloo and have lunch with him to find out. That was our graduate student interview. It was a quick meeting at about 11:30.
Was that at the grad house?
Well, it was in his office first.
Oh, okay.
I don't think I've ever had so many cotton balls in my mouth. And he's asking me questions and I'm trying to answer. And I was on pins and needles. My palms were sweating and the whole bit because I knew of him but didn't know him. Yeah. And I remember then having to go have lunch, and I was so nervous just having lunch with him, and the conversation continued, which I thought was a good thing. We weren't sitting there in complete silence. We were getting on quite well, but from that, yeah, then going off to the furthest extreme of being his lead instructor, and continuing on that journey has been just a dream come true, to be honest with you. And sometimes I still pinch myself, like, am I really doing this? Now I have conversations with him on a fairly regular basis, and we keep in touch, and we're constantly checking in on how the Backfitpro team is doing and whatnot. So it's incredible experience for me. And no, I didn't sign up for any of this, to be honest with you. It's a bit of serendipitous luck that it all folded together the way that it did. I thought I was just going to go and get a Ph.D. and do some research, and this whole new clinical training world opened up to me that I really didn't know what to expect.
Were you hoping to do some academia after that PhD, or what was the plan? Because you were a doctor of chiropractic medicine at that time, right? And
yeah, so I did my undergrad at Brock University, and I had kind of an interesting run-in with biomechanics there. That's when I really got passionate about biomechanics. We had this really tough prof, and he'll love me saying this story, really tough prof, and you either hated this guy or liked him, because if you worked hard, you liked him because you got rewarded well. And if you didn't like him, you did abysmally. Sounds a little bit like Stu's class, eh?
Yeah.
So anyway, I decided I was going to like this guy, and did really well in his course, and then became one of his undergraduate helpers in the biomechanics lab. And I remember we were having this conversation about, his name is Dr. David Gabriel, and I said, David, I don't know if I want to be a doctorate in a clinical field or a researcher. I'm really struggling. And I remember him saying, Ed, do you wonder why milk bags are opaque? And I thought for a minute, and I took the question at the time fairly literally. So I said, well, no, I don't. And he said, well, do you like people? And I said, well, yeah, of course I do. I love people. And he said, well, I think you should be a clinician.
Right.
And that was kind of it. But funny enough, and as I reflect on the conversation after, I didn't take this away at the time. It wasn't one sentence before I did ask him, so why are milk bags opaque? And he tells me the story, and I haven't fact-checked him on this, so I'm taking him for his word.
Yeah.
But he said, well, back in the day when they brought milk in glass bottles and set them down outside the house, the ultraviolet rays from the sun would hit the glass, neutralize the B vitamins, and people were getting B vitamin deficiencies. So they thought, well, we better put this in an opaque container so it's not exposed to sunlight. So anyway, that's why your milk comes in opaque containers now, according to David Gabriel. Okay. And it didn't dawn on me that I was in both of those camps. I enjoyed people, but I also was quite curious about a lot of things.
Yeah.
So long story short, I went to chiropractic college and then met 3 PhDs in biomechanics. There are 2 trained by Stu, and then 1 trained in the United States, and worked with them in the lab and did a little bit more undergraduate research there and published a paper, and then got really excited and decided, hey, I'm all in. I'm going to go to Waterloo. I'm going to look up this guy named Stu McGill and see if he'll take me on. And like I said, that meeting, I actually saved, after that meeting at the grad house, Stu called me up. He got my answering machine and left me a message that I was accepted into the master's program. I left that message on my answering machine until I moved out of my place in Toronto. So it was on there for a good 3 months, and played it a few times.
Man, I know the feeling. I know the feeling of going to the grad house with Stu too. That was his place. He loved taking people there, and whether it be lab outings or whatever. But yeah, I remember when I got that acceptance into the master's program with him. I did it like some undergrad work with him, and then when I applied over, it was just a thrilling experience to do that. With what you're doing now, do you have the same sort of interest that he has in, like, on the high performance side? Like, is that something that you enjoy working with, or do you like to work more on sort of I don't know if it's like the everyday patient, or I know you folks get the worst patients regardless on where they lie in terms of their level of activity, but I know Stu has this real deep interest in performance and training and that sort of thing.
Yeah, and my background, which I'm now sort of ashamed to admit, is when I was a student at CMCC, I wondered, like, this guy's so big in back pain. What on earth does he, like, hang around in gyms for, and what's he doing with all these, athletes? And, I realized quite quickly, I'm happy to say, that I was so wrong on that. And everything that we've gained from working with and understanding how athletes do their thing goes right back into the clinic with, a patient who can't get out of a chair without pain or off the toilet without pain, and suffers on a daily basis with the most routine things. The coaching strategies are often some kind of a hybrid or morph of something that we've learned from working with athletes. So in fact, just this morning, I was seeing a patient who was, I don't want to give too much away, but they were a Canadian junior champ in Olympic powerlifting. Olympic lifting. Yeah. So I do have curiosity about how they train and what they're doing. And then, of course, similar to Stu, all of them still have a component of back pain. Not always disabling them. In fact, the young fellow that came to see me today is like, a lot of people don't take me seriously because, my back pain is only there when I'm going for peak performance. But what you learn about some of these guys who are in the gym setting records and in any sport really, their passion, their activities of daily living are their passion. It defines them and who they are. So, I can't even imagine how you would diminish someone like that by saying, well, you really only have this problem when you're at an elite level. Like, you should be thankful that you can do all the things that you can do and it's just so off-putting that he looks around at his peer group and says, well, none of my peers have this problem, so there's got to be some kind of solution that I can find. So cracking into cases like that, is a lot of fun. And a big responsibility too, because at the end of the day, you've got to get them out of pain, but also performing again. It's not just one half of the equation.
So on that, what would you say is a big difference from patients that you work with who are high-performing athletes versus those who are, just the average person, but then the back pain is at a similar level, they're both experiencing this debilitating, lifestyle and pain. What would you say are the differences between those kinds of patients?
That's a really good question, Rupesh. I'm not so sure that there's a lot of difference between the patients. There's definitely a difference between the approach and maybe the approach that I take with an athlete and a non-athlete, and there's certainly a different skill set from the clinical world. I mean, this poor kid, I say kid, he was 20, well, I don't want to give his age away, but in his early 20s, so he's no longer a junior national athlete, but in his early 20s, and, had been to 15 clinicians. I was the 15th, and I looked him straight in the eye and said, I hope to heck that I am the 15th of 15 clinicians. Yeah. Because it's not just a clinical problem, it's also a functional mechanical problem, and a lot of clinicians just treat the pain without treating the function, and that gets them some results. At the highest level, though, it doesn't cut it more often than not. You've got to train the dysfunction out of the system, and it didn't take me long, unfortunately, with looking at him to understand why he had the injury presentations that he had and what we were going to do about them. Now, putting that all into action took a few hours, and he's coming back at the end of the week for another session to iron out some more movement patterns and some of his sport-specific training. So it's a bigger job for me, but I don't know that the people are that different.
Yeah.
I think a lot of us at the end of the day, if we boil it down, are similar.
I was thinking, yeah, that's interesting to hear. I mean, I was thinking maybe like the awareness from, like body awareness from somebody who's a high performing athlete versus someone who's just the average person. Maybe the higher performing athlete might have higher body awareness, but then you're telling me like somebody, the average person, again, maybe has gone through 15 people. At that point, you're probably pretty damn aware of what's going on. Well, not maybe what's going on, but more so just how things are lying within your body, right? Like if you're going to ask some questions, they could probably give you some really specific pinpoint things, or if you're telling them, hey, do you feel this here or that? Like they probably are very hyper aware at that point. I was also thinking maybe about the motivation. Like, do you see a different level of motivation or drive from those higher performing athletes? Because, again, that's just the world they live in. But maybe the pain is so debilitating for the average person that they're just as motivated. I don't know.
It's a mixed bag, and it depends. There's sport differences as well.
Yeah.
But it depends. Like a high-performing CEO that has back pain that's preventing him from maximizing his job performance is every bit as motivated as a high-level athlete. That's a good point. It's not the physical demand of their job necessarily, although they don't realize it is. It actually is. It can be every bit as motivating factor. So people are people, and you got to peel them back on the individual. I don't find camps of highly motivated or unmotivated people, and I try not to prejudge anyone's motivation before seeing them. I've had, and back to your point on motor awareness and whether or not they're in tune with their body, there's some phenomenal athletes, and my experience goes back, my clinical experience with Stu is shared for 3 years. So before he ever sent me a patient, I saw every patient in our old lab with him. So he, that was our Wednesday. He said, clear your schedule, Ed. You're coming with me every Wednesday, and we're going to see patients together. And for the first 2 years, I just sat and was a fly in the wall, and it was the best experience ever. I didn't have to be hyper focused on the patient. I could watch how Stu interacted with the patient and just see the whole clinical perspective from a third person's perspective. And then he started bringing me in and asking me, okay, well, what do you think about this? And the questions started to come faster and faster, and the influence, okay, well, Ed, why don't you go down that logic? And then it became, okay, Ed, why don't you start booking some of these consults in, because I've taught you, I think, more than enough to get you going. And that was after 3 years of watching each and every patient with him. So I had a tremendous clinical experience during my Ph.D. that I never signed up for, but boy was I a lucky beneficiary of.
Yeah, so. And like that experience in itself, like I don't think many would have gotten, if any, in that lab. And so what have you in your approach now, like I've seen Stu kind of do his magic. How have you differed from your approach compared to what Stu does now?
We do essentially the same 3-hour assessment.
Stylistically, though, do you find yourself maybe like being a little different in different ways, or?
Oh, sure. There's definitely nuances and differences.
Yeah.
But there would be from any person to person. But I think he would be the first one to say that. I think he would say this too. I don't want to speak for him, but he's probably got as close to a clone out of me as out of anyone, I think. There's another great clinician and instructor with our group. That's Joel Proskowitz in England, and I think the three of us are pretty much on the same path. But we're training master clinicians all over the place, and a lot of the training for the certification process is through us. But then once they get to the master clinician, they work with Joel and I as well as Stu, and we are trying to fill the need for more people. So,
Mm.
you know, there's more of us, and we're doing everything we can to grow more capacity because the demand is there. And just on a human side, the thing that kills me is when you hear these stories about how many clinicians, like this young guy this morning who had seen 15 clinicians, and I think at his age, in his early 20s, how is that even possible?
Yeah.
So, yeah, I mean, there's not a great deal of difference between how we operate. The 3-hour assessment is laid out very similarly, and from working with him in my Ph.D. for 8 years, and watching every patient he had for 3 years, an untrained eye would have a hard time telling the difference between our assessments.
Yeah. If you're hearing footsteps above me, that's just my 4.5-year-old daughter jumping. So if there's some thuds, and if folks
No
are hearing some
problem.
thuds, that's what that's all about. It's
I
kinda hard
can't
to
wait
edit.
till I hear my 5 and 6-year-olds. So far, knock on wood, it's been okay.
Yeah. That's really cool. Did you have back pain growing up? Like, was there a link here, or what was sort of the connection for you to want to get into the space?
Yeah, definitely. That goes back to my high school days. I was playing on the time on 5 volleyball teams.
Yeah. Okay.
A year. So I played on my school team and the club team. I played on a regional team for beach and a regional team for indoor.
Okay.
And then another city-to-city team in Canada-US games. And
wow.
My high school was probably the biggest beat up on me. It was on concrete floors in an old school that was built, you know, pre-World War One. And we practiced 5 days a week for a really intense short season, but it was 5 days a week. And that was brutal on my back. And I remember takeoff and landings, just an excruciating pain. And my mom had a friend who was a massage therapist, and she said, well, bring Ed in to see our chiropractor and get an assessment. And funny enough, my first experience with chiropractic wasn't great from a person point of view, but he managed to treat my SI joint well enough to get me back on the court. And at that age, I put up with his style of practice, which didn't really mesh with my own. And the results, he got the results that I needed at the time. So
what was your issue?
That was my exposure. It was a SI joint issue.
Okay.
And all that jumping and landing was causing a lot of shear on basically a very aggravated SI joint. And eventually it went away. It would come back every once in a while, especially with long hours sitting in lectures. It's so nice not being a student anymore. So that was my first experience. That's how I got interested in chiropractic. And then my now wife, then girlfriend's father was a chiropractor. And so I got to see that, you know, job from the other side. You know, when you're a kid watching like Law and Order and you think, oh, I want to be a lawyer, I want to go in and argue in front of court. And then you realize when you grow up that lawyers don't really spend a lot of time in court. It's reading documents and articles and whatnot. And so you really, you know, you take the sort of TV version of it and you twist it around, and it's not so great. But I saw it from behind the scenes, and I thought, wow, that's really neat. You get to interact with people, and you're trying to help them, and those were big motivational factors for me wanting to be a chiropractor. And you know, a few years down the road, my wife and I now both work out of his office, and we all work together, the three of us. And
cool.
It's fun. We all have our own specialties in the clinic, but
What about the field? What about the chiropractic field? Sort of. Do you think people don't quite grasp, and is actually maybe to the detriment? Like, and what parts of the field are you just frustrated with? Like either the teachings of it, or because I think chiropractors sometimes get a bad rep, but sometimes I also feel like sometimes you don't get some really good ones, right? Like people ask me sometimes, like, hey, I'm nervous to go to this chiropractor. I'm like, yeah, you know, there aren't that many good ones from my experience, but sometimes you get some really good ones who have a good clinical eye, and But I don't know, just curious, because you're obviously a chiropractor, you've been through Stu's method and all that. What's your view of the field overall?
Well, that's a good question, but to be fair, it's not unlike any health profession. And what I mean by that is constantly when I'm doing consults, I'll be asked, I've driven 3 hours or flown from across Canada or the US to come and see you, Ed. I need someone in my hometown, like, can you recommend a chiropractor or a physical therapist? And I say, well, no, I can't, because I don't know them. And if I don't know them, I can't recommend you. Truth be told, Rupesh, life's like a box of chocolates. You never know what you're going to get. And there's some nuts in some of those. Yeah. So it's not bounded by professions. And I think you're right. I think the chiropractic profession has a reputation that is not totally deserved across the board. But that's an issue of, funny enough, cultural authority. So there's a topic for another podcast. Physical therapy and medicine have cultural authority. So when you go to a bad MD who doesn't know that they need to order an MRI because you have a suspicious cervical spine problem that's causing balance disruption, and you need to look at cervical spine and probably a brain MRI as well, you just write it off and say, well, that individual doesn't know what they're talking about or doesn't know what they're doing, but medicine as a whole isn't. And because chiropractic hasn't gained cultural authority, it lacks that one-off mentality, and people often write off the whole profession. There's fantastic chiropractors out there, and there's some terrible ones. And there's some fantastic physical therapies out there, and there's some terrible ones. Yeah. There's some fantastic MDs out there, and there are some terrible ones. And unfortunately, I'm biased because my patients, for the most part, have all seen the terrible clinicians. And I can tell you it's not uncommon for me to have a consult patient who's seen 3 to 5 chiropractors and 3 to 5 physical therapists, 1 or 2 neurologists, and a spine surgeon, whether it's a neuro or an orthopedic spine surgeon. And it's not to say that I'm better than any of them, or that I'm some kind of phenom that's out there just striking 1,000% all the time. It's just I see the worst, and I don't understand. I think I see the worst because they've been to some clinicians who've just either been too busy or burnt out. And we know the healthcare crisis right now in Canada with the pandemic. I mean, those of us in the healthcare system have been talking about how the healthcare system has, been pushed to the brink prior to the pandemic. Now, finally, with the pandemic, you always got to find the shiny side to the coin. At least the whole population is now sharing in that theme and realizing that the healthcare system was pushed to the brink and nearly broke. And arguably it did, with all the public health measures that had to shut everything down. And it was for good reason, because our healthcare system couldn't handle it. Now, do I agree with all the lockdowns? No, but we had to do it because we didn't have a healthcare system that could sustain the demand. So it's a necessity.
For sure. What would you say is, because I mean, it's just mind-boggling to me. I mean, that someone has to go through all those different specialists and practitioners and such, and you hopefully over time, as you keep seeing somebody else is just, they're adding a little bit more value to the situation. But 15 people, what would you say is the missing ingredient? And it's not to I know the Backfitpro method is, and all you folks are incredibly humble people. But what is that missing ingredient, would you say, that comes with that approach versus, or just is it an educational deficit? Is it the training in schools is not is not done the right way? What's missing for people that people can't have to rely on the Backfitpro method or someone being McGill certified, which is awesome. That program has been created, right, to kind of fill the gap. But it doesn't start with the McGill method, it starts with starting in an institution, right? And so if people are not getting that proper institutional learning, and then they're having to depend on certification afterwards, I mean, yeah, what's missing?
Fantastic question, and you're right on the ball. As I recall that you were back in your master's days, Rupesh. What's missing is a system change. So I'll point the finger back at me,
Okay.
and I'll tell you a little clinical story of my own. So I was right from CMCC. I went right to work, and for the listeners, CMCC, Canadian Memorial Chiropractic College. Went right from CMCC to University of Waterloo. And I remember I was waiting for my license at the time. My father-in-law was excited. He found out that I was working with the Stu McGill. He was, beside himself. I heard him talking me up to patients. My future son-in-law, I think I was still at that time. I was for one more year. And he said, "Okay, Ed, as soon as you get your documents, I've got some patients lined up. They're going to come and see you. I've been working with them, but just not getting the results I want, so I'm going to send them to you." I said, "Fantastic, so excited." So I call up the Ontario Chiropractic College, which is the licensing body, and said, "I need my license. I know they're coming through in the next little while, but I have patients booked." And, this was on a Monday. So I bluffed a little bit, and they said, "Well, when are your patients?" I said, "I've got patients booked Thursday afternoon, so I need my license number." "Well, okay, we'll see what we can do." Well, sure enough, doesn't it come Thursday morning? Now, I obviously would have had to cancel the patients to not practice without a license, but he would have seen them anyway. So anyway, long story short, I'm in there. This is my first day of clinic. I'm literally on the day of getting my license. I'm going to see Stu McGill. I'm like the most pumped up individual in the world right now, like first patient out of the gate. Nobody's got to sign off on it. No master clinician at the college. It's like, this is me. That's the only barrier between me and this patient getting better. And just before I walk in with the patient, he says, "Oh, by the way, they've been a really good patient in the clinic, and I know you're going to do your own assessment and an exam, but we're just going to charge them for a regular visit, but take as long as you need, and they know that you're going to probably take a bit longer than I would on a usual visit." So his visits at the time were probably between 5 and 10 minutes.
Okay.
I spent almost an hour with the patient. I did an assessment. I did some provocative testing. I told them what I thought was going on and why they had a certain amount of success but weren't getting over the hump to get off the dependency and need for ongoing treatment at the current interval that they were at. And if they would do this plan, and then I show them the whole plan and walk them through it, they could probably go, a much longer time between treatment intervals and be able to get out and enjoy life and all that good stuff without being dependent on sort of the system. And I remember this like it was yesterday. I looked down and I said, "Okay, well, that's what I want you to do." And I was sort of wrapping up my last sentence, and she looked at me and said, "Ed, isn't there a pill I could take instead of doing all this work?"
Oh.
And I thought, that patient had no value for what I was doing. And one of the reasons was they weren't being asked to have any value for what I was doing. They were seen as a regular follow-up visit, which is, about a third of the cost of what we charge for an exam in the office, and there's a reason for that. We're spending more time in the exam, a lot longer time, and she just had no value for the treatment. So clinicians nowadays, to come back and answer your question, which is the same as I was, are stuck in a situation where the gal down the street on this side and the guy down the street on this side charge X dollars. And it's hard for patients to know that there's more value and more price. Now, we always say you pay for what you get.
Right.
But the system is designed that, there's a lot of inertia keeping it where it is. It's hard to move the bar up. It's hard to elevate everyone's game around you so that you can charge more and spend more time with patients. But that to answer your question in a roundabout way, is what I decided I had to do. I had to change the way that I practice. And that's when Stu's work and all of understanding how he spent 3 hours with a patient made sense to me. Like, it was just, I'm going to get more out of it. They're going to get more out of it, and we're going to get something accomplished. So it's a product of the system. To be honest with you, and to answer your extra questions around that area, I think CMCC, which is the Canadian Chiropractic College, is doing an amazing job of education. And, you know, I say that full well having no relation with the faculty, but knowing who they are. They have 3 of Dr. McGill's graduate students over the time, 2 Ph.Ds and another top-notch master's student teaching for them in biomechanics. They have Ph.Ds in all the respective areas, teaching all the basics and foundational sciences, and then excellent clinicians. But then the student, equipped with all this knowledge, goes out into society where this establishment has said, pigeonholed you into a box, and it's very difficult to break out. One of the things that allowed me to break out was being associated with Stu, because right away that immediately elevated my game. And, you know, with, you know, that old saying about superheroes, with more responsibility and more power is more responsibility. So it goes hand in hand, and it's difficult to change the entire system, but that's what you guys have to do in health policy. Yeah.
You know, when you brought up the example of, you know, someone seeking treatment and there's one clinician here, one clinician there, and maybe one clinician charges a little bit more. Let's just say, even if it's an MD or whatever, I think though people have a right to expect that, you know, I think people view just general MDs as more than triagers, but really, like, for the most part, they're really, for the most part, triagers, right? Like, they should be pushing people to different specialists. I mean, obviously there's basic things that they should and are completely capable of doing, but like, even from an MSK, a musculoskeletal perspective, right? Like, I think people try to think that, okay, at least there's some basic things that they should know about, you know, MSK issues. And I'll give a little quick personal example. I remember I was walking home one day, and then all of a sudden my thoracic ribs just like seized and contracted, right? And it was like something different, and so it was just odd to me. And I remember talking to my dad, and he was like worried about my kidney or something like that. And I was like, no, it's not that. And he's like, just go see an MD. I was like, it's gonna be a waste of time. Like, I know this is gonna be a waste of time. The guy didn't even like physically palpate me or anything. Like, just like, go take, you know, an NSAID or some pain medication and you'll be fine. And I go to a chiropractor who I respect here in the city of Edmonton, and he's like, you got a sublux rib, man. And he's like, it's not rotating or whatever, and he adjusted and it was fine. You know, whether that was the case or not, but I think people expect some basic level of knowledge and service that is actually like true. And time again, whenever I heard, whether it be Stu in his class or whenever I've talked to him, he always amazes me with like the cases that come to him and be like, you know, how is this not seen before, right? Whether I remember he told me a case of where somebody was I think it was at Waterloo, and somebody had walked by my grad office, right? And he was completely almost at 90 degrees, and he knew he was walking to Stu. And then Stu told me after that this person, you know, what the reason was is because there was a tumor or something pressing against his hip flexor. And how could you not see that on a basic scan? Like, you know, so there's some basic things that I think people expect clinicians to have, which I feel like some clinicians are just failing people overall, right? Like, I understand there's different specialties and expertise levels and all that. That makes sense to me. But there should be some basic things that can avoid that can then prevent people from having to go and see a really, really pricey practitioner. Especially there are many folks who don't have that kind of money to, unfortunately, spend on 3-hour assessments, as much as, you know, they should be done that way, right?
Yeah, I completely agree. And to defend medical doctors, one of the interests I had when I was at CMCC was actually in a group that we called ourselves the DCMD club.
Okay.
And what we were trying to do is connect bridges, or it was called building bridges. And we were connecting DCs to MDs, and then it expanded to all other health disciplines as well. And it was amazing. One of our profs at the Chiropractic College was actually faculty cross-appointed at U of T. And this may come as a shock to you, but they were given 3 hours of musculoskeletal in-class education. One of those hours was dedicated to low back pain.
Sounds about right.
So to the defense of the medical doctors, it's not their area, yet it is the second highest reason someone presents to their family physician, the highest being upper respiratory.
Yeah.
And they have to know, to their defense, so much about so many things that I personally know only the surface area enough to, as you say, triage and recommend and refer out for in the suspicion of some kind of sinister underlying pathology. They could do a better job of having a better baseline MSK knowledge, but there's a lot going on that they have to be responsible for. The whole field of genetics and medicine is taking off like crazy. There's so much information that we don't cover at Chiropractic College because we are focused on MSK and that educational bracket that, you know, we have differential diagnosis to rule out tumors and pathologies and all those kinds of things, but that's where our education on that stops. It's identifying it and ruling it out and sending it out when we need to.
And that's fair, and I appreciate that. But if I could just play devil's advocate for a second. I mean, I think there's, though, like basic anatomy. You know what I mean? Like just how muscles pull on each other. Like, I mean, I don't expect an MD who maybe doesn't have like a kin background or something like that to know exactly all the muscles and how they connect and like how they pull and everything like that. But I mean, it's not that difficult. I remember in one class, Stu pulled up a picture of like a bodybuilder with his glutes, right? And he's like, what's the primary function of this muscle, right? And everyone thinks the glute is a hip extensor, right? But you look at those striations and like, no, it's an external rotator, right? And it's like, it doesn't take much, right? You know what I mean? And like the anatomy tells us so much about what's going on, and just understanding that could just help in terms of whether it be direction on who to send somebody to, or just understanding the problem, right? There's not even that sometimes approach of really wanting to understand what's happening. And even that could give a lot of comfort to patients, right? Is just that MD spending that time to just understand that person's problem. And even if they can't get to the root source, but at least that understanding and then applying some basic like anatomy and knowledge could go a long way, because it doesn't take much.
Well, and just to double down on my perspective, one of the cool things at CMCC is they did hire the best that they could find from wherever they could find them from, and that includes across the world. So our anatomy department was actually filled with medical doctors with PhDs in anatomy. So they had PhDs in anatomy that they'd done some kind of novel discovery and part of their thesis and work, but were also medical doctors, usually foreign trained. Some of them fantastic clinical experience in their own countries, came over to Canada, couldn't get hired into our system because they weren't recognized for whatever reason. And selfishly, we were the benefactor of them because they were phenomenal. And they'd said, you know, one of them got to know me quite well, and he said, Ed, you know, I love teaching at CMCC, even more than other medical schools that I've taught at, because, you know, in medicine, they flip the cadaver front side up just to open up the skin, have a look, flip it over for 2 weeks, look at the back muscles in the same way, remove the skin, have a look at the muscles, and then flip them over, open them all the way up, and now spend all their time internally on all the organs. Yeah. And it's a product of, again, how much they need to know about all the other things. And so to go back to your first question about triage, I think they're underplaying their own expertise, to be honest with you. I think you could have nurses and nurse practitioners being the triages of the system, and have, you know, the MD, even the general practitioner, as one of those triage outlets for a whole host of categories of issues that maybe didn't need a specialist from another area, and it would free up a lot of people. Now, the problem with that, of course, is we've all heard on the radio over the last, 18 months, the massive shortage in nursing, and the migration south, unfortunately, of a lot of our nurses going down south where they can make more money and have a better quality of life. So there's massive problems in the system, which isn't new, but I think our colleagues in medicine are doing some great work. Again, I don't think it's the profession as a whole. I think there's individuals clearly dropping the ball, but there's chiropractors dropping the ball too.
Sure.
So
so being a nurse practitioner, I find them amazing. Like, I am working with one right now, and I find their approach just refreshing, because they do a very long intake. They take their time to understand things, and it's an interesting idea for them to be maybe that first point of contact, or a triager, and then that's interesting. In terms of like what you're seeing, I mean, you know, I feel like people are referring to online even more so these days for medical advice or fitness tips or whatever, and I have no doubt that you've probably come across patients who are just like, I tried this thing and it messed me all up, or whatever it might be. But what comes across your table and into your room, into your clinical room, as you're just like, I wish these fitness trends or these approaches just didn't really exist? Like, what really bothers you these days from what you see online?
Yeah, well, Dr. Google, as I call him, and all of his colleagues, the Instagrammers and the Facebookers, and it's amazing that they're so confident to give out advice without knowing who the individual is in front of them. One of the things I do with all my patients is I go through a 4-page informed consent. It's actually a spin-off of the one that we had at the university. And I sent it to my college, and I said, by the way, I'm not using your 1-pager, I'm using my 4-pager, and here's all the informed consent that I want to give. And they took one look at it and said, wow, that's phenomenal. Go ahead, use yours. So I go through a 4-page document outlining everything that they can expect from that 3-hour assessment and then the ongoing follow-up. And it never ceases to amaze me that patients are somewhat surprised that the process takes that long. Some of them who aren't as familiar with Backfitpro and the Biomechanical book and some of the other resources. And I said, well, you know, I haven't got a clue what to tell you about your back right now, but in an hour and a half from now, I'm going to have some very specific guidelines for you to follow and hypotheses to test, and then we're going to test those, and we're going to have a very clear indication of some guidelines for you moving forward. But right now, I don't know what to tell you about your back. And, you know, the trend is pervasive in kinesiology, if I can put it that all under that umbrella, in nutrition and personal training and fitness. And, you know, there's so much out there. And if I could tell, you know, your audience one thing, anything you get for free is probably, there's a reason it's free. It's probably not worth much, or it might be worth something to one segment of the population, and totally not only not worth much, but dangerous and damaging to another population. So I guess consumer beware with what you're consuming on the internet and what an internet guru is telling you about, and then figure out, you know, what their training is and what their perspective and background is beyond the hype. Because if there's not some credentials to back it up, then I would be pretty weary about it.
For sure.
It takes a long time to hone your craft and to be really good at what you do, and that goes from being a master car mechanic or a master clinician. And in the world where everything's instantaneous, we get students who are new to back mechanic and taking our courses, and one of the first questions out of their mouth is, how do I become a master clinician? And unfortunately, the answer is often a lot of years of really hard work and dedication, because you're not going to get there overnight. And it's no different than what all of our mothers used to tell us: work hard.
Yeah.
Work hard and good things will happen.
When you spoke at the start of this question just around that tailored approach, and how can you get that from an online source or through Instagram or whatever. But are there any sort of just complete sort of no-nos for you, like when it comes to I don't know, I guess we could talk about the spine in particular, but I think about traction, for instance, right? You see that in the idea of traction, and especially for those who have disc herniations or such, right? I mean, for someone who doesn't understand how the spine works, I mean, the logic seems pretty simple to me, right? Like, you stretch things out and you open things in, the disc creeps back, and it's all good, right? You're ready to go again. But like, just thinking about those kind of things, like it doesn't you don't have to require a tailored approach. There are just some bad things, and I mean, we know from Stu's stuff in terms of like, don't do sit-ups, right? The guy who killed sit-ups sort of thing. We know like those kind of things are just no-nos for pretty much anybody. But what comes to mind for you? Like, are there any sort of fitnessy tools or gimmicks or things that you've seen that are just like, people should just stay away from that entirely?
Well, I would say anything that's not specifically geared to that individual. And so, you look at an exercise and you think, who might benefit from that? And then you look at who the audience is of the individual spreading it through the internet, and you think, well, that's not even close to their audience. There's some exercises that I have no problem giving to the Olympic lifter I saw this morning that I wouldn't dream about giving to the 50-year-old banker who I'm going to see tomorrow. And so, Stu and I have always said the tools of back pain are pretty simple, but knowing where and when and how to apply them is the hard part. So I don't know if I would write anything off right out of the gate. There's some fundamental rules about the spine that you can certainly hedge your bets on. So rules like, if you can minimize spine power, that would be to your advantage. And so for the listener, spine power is force times velocity, or the speed at which you're moving. So if you've got a high amount of load, you're carrying something that's relatively heavy. If you do a lot of twisting and turning motions while carrying it, you have a high degree of spine power. And what we see on an MRI, if you come in and that's your loading history, is annular tears around the edge of the annulus, which is part of the disc around the outside, the thick fibrous tissues that hold the disc together. They tear apart in that rotational loading pattern. But there's times when an athlete, for instance, has to rotate as part of their sport. So you can't say that you can never rotate, but certainly how you dose it and limit it, and how much of your hips get involved. My whole Ph.D. thesis was on the hips and the linkage between actually spine problems and knee problems. And Stu and I think, both look at it the same way, as the hip is kind of the keystone. So if you know how one of those old arches is made with big stone blocks, the keystone is the one right in the middle that has the compression going down, ideally through the bottom stone at the bottom with the right angle that just puts the whole archway together. And if you don't have the keystone in place, the whole thing crumbles. Well, the hips do that in a lot of ways for the spine and the knee. And so we think of it as a bit of a keystone in that whole kinetic and kinematic chain from the knee to the hip to the spine. But it's hard for me to, there's always well, what about this for instance. So to make a blanket statement across the board is it's difficult.
So tell me about how like the hips and the knees connect. And I guess what I'm saying is that, you know, I know a lot of the focus is to, like you talked about, you know, spine power is probably something that we just want to avoid. Obviously, some activities you just can't prevent them, and so transfer a lot of that load and that power to the hips, right? But what's the consequence of that, I guess, on the knees? And is there one? Because, I mean, we're hearing more and more, I guess, in the more mainstream public about how we need to let our knees not be so restricted, let them go over your toes, and not have, you know, not just simply rely on that hip hinge, but just, you know, let some of that transfer over to your knees and let them go beyond your toes. So just wondering about that interaction and whether one is of consequence to the other and that sort of thing.
Yeah, well, let me narrow down the discussion a little bit so I can
Sure.
be more specific. If we leave it too broad, then it's hard for me to make some specific comments. But first of all, loading at end range for any joint is an issue, whether it's the hip, the knee, or the spine, because at the end of the day, you're going to be loading the passive tissues quite a bit. So as we get to end range, everything starts to stretch, our muscles stretch, the length-tension relationship between the muscles is at its maximum, and so we're getting a lot of passive muscle force. We're also getting the ligaments and joint capsules starting to stretch and respond. And the cool thing about the hip is that for a lot of us, even us guys with Celtic backgrounds, which we can talk about, differentiating them from someone with an Eastern European background or an Asian background, still have a lot of range of motion in our hips, and usually more than enough to do, say, rotational sports like golf or baseball with quite a bit of hip power, and still nowhere near end range. And so when you're loading a synovial joint through its normal range, it's relying on active muscle strength and stiffness. When you start getting to end ranges, you'll see on, you know, different social media accounts, well, it's okay to, you know, bring your knees to your chest, or, you know, get a maximum hip flexion, disregarding spine posture and all that, or go in and do some deep squats and you know, put your ass to grass, as you know, they commonly talk about. End range knee flexion, going after full calf on thigh contact. The lab just down the hall from us, after you left Waterloo, there was some knee biomechanics coming in trying to model how that actually pulls the joint apart and stretches the capsule even more, because now there's a fulcrum between the calf muscle and the thigh muscle, and the knee pries itself apart. And so there's a lot of mechanisms that are starting to become understood, and there's definitely a lot of mechanisms that we do understand that says end range loading is probably not a good thing at nearly any joint. And so that's sort of a general comment. But more specifically, if I take an example of a trade-off between, say, a front squat and a back squat.
Right.
The line of drive shifts between the front squat and the back squat, but so does the distribution of load and force, because as you migrate the load further forward, you may take some stress off the knee, but you're now putting it on the hip and the back through an extensor motion. Whereas when you're in a front squat and you move the line of force back and you sit a little bit more upright with your body, you decrease the moment on your back and hip, but you increase the moment on your knee. So there's a trade-off with everything. There's never going to be a win-win scenario. You're going to optimize something. You're going to, you know, try to minimize both or maximize one and minimize the other. And again, it's not that the front squat or the back squat is a preferred exercise for everyone. There's specific reasons to have a back squat or a front squat, and whether or not you want to develop hip extension or whether you want more knee extension, it's very sport and situation specific. Again, another example of that interconnection between the knee and the hip is with female athletes, particularly basketball and volleyball and soccer, with non-contact ACL injuries. In basketball, the rate of non-contact ACL injury, if you have a controlled study and look at NCAA men and NCAA women, they have as much as an 8 times greater incidence of non-contact ACL injuries. And that comes down to a difference between the neurological patterns that activate glute versus the quad. And if you get your knee in what we call a dynamic valgus position, so the foot points outward relative to the knee and the hip, you think of it as a hockey stick, if you can visualize that in your mind. If that knee moves medially towards the inside and the foot's planted on the ground, you're now creating a large bending moment around that knee. If you go ahead and activate the quad first, you're going to stress the ACL ligament. However, if you externally rotate, as you brought up with the glutes, and activate glute max and align the knee and then create the extension through the knee joint, you will bring the stress off the ACL joint and into the muscles. So you mitigate the risk for an ACL injury. So the downstream isn't always upfront and obvious. And I think that's where a lot of this online presence of online training fails to go down that road of, well, what's the long-term effects of what I'm recommending and having, broad-facing opinions on. If I was to tell everyone they could benefit from one exercise, it would probably be walking. That would be an example of a wonderful exercise that the vast majority of the population would do quite well on. Cardiovascularly, we know that, believe it or not, walking is a pretty good cardiovascular exercise. In terms of joint mechanics, it's not a lot of stress on your spine or your knees or your hips. It's well within tolerance. And it's good for the ticker, it's good for the joints, it's good for bone health, it's good for balance, it's good for so many things. But there's so many exercises that are really sport specific that have become so popularized. And I think, well, why on earth would anyone recommend that across a large group of people? And I don't want to, as you know, I don't want to center anyone out or name any particular exercise, because there's no bad or good exercise. It just comes back down to who's your audience and why are you making the recommendation.
No, and that's perfectly fine. I think sometimes just some online trainers or whoever, they make it seem so easy for people to understand certain things. Like, so for example, on like the letting your knees go past your toes, I mean, you can, there are many common movements where your knees just naturally go over your toes, right? And that happens. I studied the jump, right? As much as, we focused on, it was hips versus knees, but as you're jumping, there's no way of avoiding your knees going past your toes, right? The amount of power that's being generated from your hips is naturally going to shift those knees forward, right? And so I think then people just generalize that and be like, well, look, these movements, your knees go over your toes, so let's just always do that. And our trainers have been telling us, well, when you're doing a lunge, don't lunge where your knees go over your toes. So they make it seem like, okay, that can be so applicable for everyone. But what I'm hearing from you is that, that might be catered to a certain audience. Maybe there's a place for that, but there might be some audiences that might not benefit from that.
Yeah, you got to start looking, if we're talking about training, about dosage and volume and weight. If you're going over with body weight versus going over with, say, 200 kilos on your back, those are two very different scenarios. So the specificity continues to drive down the answer to give you a specific answer, but it's very difficult to get an answer with too many generalities, and I guess that's my issue with what I see, and it's my issue because I see it with my patients. They come in and they say, I was watching this, or I got this advice on TikTok or Instagram or Facebook, and I think, my goodness, no wonder you're in quite the predicament, because you're just, and they say, well, I've got 2 friends that it was okay for, and that might be true. They may have been fine, but they didn't have your specific history and this underlying back problem that you've been sort of just floating there underneath the surface. So to me, it all comes down to specificity.
I'm going to start shifting away here. We always do these 2 final questions for every guest. I'll get to that in a second, but a couple of things. You've seen, I'm sure hundreds of patients or so, or whatever it might be. What humbles you by your patients? Like, what's something that you just, you're a wealth of knowledge, you're a master clinician, you work with Stu McGill, all these sort of things. Well, what continues to humble you about people and the patients that you see?
Yeah, that's, you did give me a heads up on that question coming, and thank goodness, because I had some time to think about it. So the answer might come off as quick, but it's only because I've had about 24 hours to think about it. If I told you I wasn't a little bit nervous, a little bit palm sweaty before every patient, I'd be lying to you. I'm constantly trying to improve and get better with every patient that I see. And it sounds like a cliche, and Stu said it before as well, but the last patient I see will be the best clinical experience I can give, because I feel like I'm constantly improving, constantly reading people better, constantly providing more accurate advice, and learning from them as much as they're learning from me. And to me, that, as well as their side of the coin, I am constantly touched by their stories of how they're dealing with and been mismanaged through the system, and they feel like no one listens to them and gives them enough time, and the psychological burden on many of the patients is tremendous to break through. And sometimes that's very quick to do, because their guard goes down when they realize I'm it for the entire morning. This guy's only going to spend time with me, and sometimes that's enough, and sometimes it takes me nearly 40 minutes just to break them down a little bit so that they're honest and trusting, and I've got sort of their attention. And even, 2 patients today I had. One I told you about, the young fella, and the other patient had heard what I had told him, but then been given, in my opinion, some terrible advice. So the clinician got the assessment right, but then gave the most, what I thought was ridiculous treatment plan given the diagnosis. He was recreating the injury mechanism that he identified as part of the therapy plan. And I thought, well, no wonder now this patient hears what they've heard from one of their, I think he'd only been to about 6 or 8 clinicians. But had heard this similar story, and he said, all credit to you, Ed, you've put it together a lot clearer than they did, but I've sort of heard a tale of this before, and my concern is you're going to give me some exercises that just aren't going to do anything about it. And I was taken back and gutted, not because it was insulting to me that he wasn't going to, buy right in, but just that I could totally understand how this was going to be a huge problem for him, because here he is again hearing a story from the clinician, and is this one the right one? And so their personal experiences are completely humbling, and they continue to come up in different scenarios all the time. And I feel for the patients just trying to get some help and get back to their lives. And a lot of these patients get lumped into boxes after they've been, it's kind of like a red flag to some of my colleagues. Oh, he's doctor shopping, and he's been from one clinic. Well, no, he's not doctor shopping. He's just trying to get better, or she's just trying to get better. And it's that's the most humbling part, I think, of my weeks and days, is just the stories from patients. It's I will admit I need a vacation every now and then just to manage all the stories and take a break and recharge, because not that I don't love what I do, but it's hard to listen to some of the stories. They're so frustrated, and they couldn't be some of the nicer nicest people in the world, but they're just struggling with this back trouble or neck trouble, and they just don't know what to do about it.
Yeah, it's wonderful to hear that initial drive or desire to work with people and your care for people. I mean, after all this time, still holds true. And that example in particular of you feeling gutted, not because they were insulting you, but like that you just couldn't connect it for them, right? Like that person didn't feel connected to what you're saying is very interesting. Are you okay if we pivot to our final two questions?
Yeah, I'll just say this. If I don't feel like that, it's time to retire.
Yeah, fair, totally. Yeah. That's great awareness, because I think some people would just continue on. So that's awesome. So we always ask these two questions of our guests. Our first question is 5 for dinner. So dead or alive, who would you want to have supper with, and would you have them together or individually?
Well, funny enough, we were having this conversation, and I didn't do 5. I said the one person you'd want to have dinner with Stu. So now I've got to listen into his podcast and find out who his 5 were. It's a good thing you gave me a little heads up on this one too, because I needed it. And the twist on the question of whether or not I'd have it together, I got to give some thought to that. So normally when I'm asked for one, and I don't want to miss anyone, so I'm just going back to my notes. I'm cheating here on your question. There it is. My first. Normally people ask me one, so I say, well, I don't have one. I have 2. And it's when you hear the names, it's going to be kind of interesting, but it's for the same reason, but they're in very different worlds. And it's Barack Obama and Tiger Woods. And most people know that my big sports are skiing, golf, and volleyball.
Okay.
And so they think, oh, well, Tiger Woods, of course, it's because he's, the greatest golfer of all time, arguably.
Totally. Yeah.
If you're my age, you think so. If you're a little bit older, then you think it's Jack.
He's the reason why I started playing golf was Tiger, for sure.
Yeah. So it actually has nothing to do with that. And it actually has the same reason I want to have dinner with Barack Obama. They both overcame amazing systemic and situational obstacles just because of their race. And, both of those things, to be the best golfer in the world, arguably in history, certainly for a long stretch of time on the planet, and to become the President of the United States are immensible, remarkable challenges to mount. And then to have the cards stacked against you, arguably, because of systemic racism, was phenomenal. So my questions wouldn't be so much about that, but and you got a little bit. I don't know if you're a Tiger fan, you heard his Hall of Fame induction speech, and you know the story about where's the first tee and what's the course record. Like, I was watching that, I was in total tears. Like, I could just imagine going to a golf course, not being allowed to go into the clubhouse. So I think both of those guys have some amazing individual experiences that I just can't even fathom. So those two guys would be on the list for sure, and probably together. And now if you're saying I can have separate dinners, then
it's your setup, man. Your
then
gig.
The Queen would be the next one.
The Queen, okay.
Yeah, the recently passed Queen Elizabeth II would be 70-year reign. She saw some amazing things through her reign and incredible changes. And the more I'm learning about her, the more she had a pretty good sense of humor. So I think that would be rather interesting. And then I think the next two might be more obvious or predicted people. But I think if I can have dinner at separate times with them again, because I think they'd be very big discussions that would easily try to overshadow each other, would be Neil deGrasse Tyson and Jordan Peterson.
Okay, yeah.
And so you can imagine that a three-way dinner between those guys might not go over well. They would try to get a word in edgewise on each other, but I think it would be, they're phenomenal minds of our generation, and I would love to meet either one of them for dinner.
Yeah, very cool.
So
and
there's my 5.
Yeah, are you with Jordan Peterson? Is that someone that you listen to regularly, or?
Yeah, I think the man's absolutely brilliant.
Interesting. Okay.
Yeah. Certainly controversial, but if you get past the initial controversy, he puts forward an incredible argument. The style at which he debates is also rather interesting. I find the man, though I know he's controversial, I think he's on an impressive intellect.
Yeah, cool. Well, yeah, it's so Tiger Woods, Barack Obama together, and did you say the Queen, Neil deGrasse Tyson, and Jordan Peterson, the three of them together?
No, they'd all have to be separate.
Oh, they all have to be separate.
Yeah. And Neil deGrasse Tyson, I don't know, like, my background is skiing, like, I love it. And he just came out with this little analogy, and it was on TikTok of all the places after bashing, TikTok users, that if you took the Earth and shrunk it down to the size of a pool ball, a cue ball, it would be smoother than anything that we can machine. So if you take the largest mountain in the deepest part of the ocean, you can't even feel it. If you could have some kind of mythical monster that was the size that you could just hold the Earth, he would think it was, or she, or it, whatever it is, would think it was like the smoothest thing ever invented, man-made. Yeah, check it out. It's mind-blowing. And that kind of stuff, just like, you think about it, and then he explains it to you about, how it's like, okay, well, that's like 8 miles difference, and, it's this many miles crossing the Earth, and so if you... Phenomenal guy. Where does he come up with this stuff?
I hadn't heard about that one. I gotta listen to that. Are you following the James Webb Telescope, like these images that we're getting back? Like, you a space guy, or?
I'm not a space guy so much as, like, I enjoy how Neil deGrasse Tyson teaches science to people.
Okay.
So, actually, my brother-in-law's friend's a big space guy. You've probably seen him on TV. He's a professor at York University, and CTV has him on all the time.
Oh, okay.
He's a space guy. I don't want to put myself in that category, but I'm definitely a fan of how Neil deGrasse Tyson can teach science to people who might otherwise say, I'm not a scientist, or I'm not interested in science. And just those examples, like, the Earth is actually smoother than a cue ball if you could shrink it down. It's like that kind of exciting, tidbit gets someone interested to, look up and understand a little bit more about 100%. Math and numbers and how it all works. So totally. I find that really compelling.
Yeah, cool. Last question. Beyond the circle of life, what do you know for sure?
Yeah, that's a tough one too. I don't know how much... you couldn't have given me enough time to prepare for that question. Well, I'm pretty certain on gravity. But that's kind of fun. In science that we don't ever really prove something to be true. We just prove the opposite.
Well, good science, good science would try to do that. There's a lot of bad science in there.
How many things am I certain of? Not many. The old joke, death and taxes, but you already eliminated half that equation. So it's a tricky one. You can easily get caught in a rabbit hole, and I'm trying to Jordan Peterson my way all the way down through both sides of the answer. And perhaps I'm coming up short, because I don't know if I have a good answer for that one.
That's okay. I mean, some people have said nothing, like they don't. And maybe that's the case. I certainly thought. I remember when I first started doing my master's, I thought I knew a whole bunch about kinesiology, and I realized I knew nothing when you start working with people like Stu and all these brilliant minds. But I mean, I'd be curious offline if you have an answer to that. Would love.
Well, and on that note, like you just mentioned Stu, and what do you know for sure? A lot of people knew a lot of things about spines before Stu created a paradigm shift. And I remember, you'll know, Richard Wells talked to us about paradigm shifts, and he said, in our area, you will live through one paradigm shift, if you're lucky, in your area of study. So for me, it was spine biomechanics, and you as well. And Stu was the paradigm shift. The whole notion of measuring stability completely changed how we understood how the spine functioned and why it's not, a ball and socket joint.
Right.
Why spine power is an issue versus hip power. So, we're one paradigm shift away from realizing we didn't know what we thought we knew.
For sure. Yeah.
Yeah.
Ed, I really enjoyed this conversation. It was great getting to know you a little bit more. I hope you enjoyed yourself today. And it was just it's fun to just get to know the person who's kind of, like I said, a lot of Waterloo students would see you and they're like, that's awesome that you get to work with Stu and work Backfitpro and carve your own path for that matter, right? Like, I mean, Stu's laid this amazing groundwork, but it's for other people to build off of, and it's great to see you doing that. And so while I don't really quite know you, definitely I feel like from being part of the Stu lab, I think we can all say we're proud of you and enjoying to see the work that you're doing there. So congratulations on that. We'll put all of Ed's info. And by the way, Ed, how can somebody find you if they wanted to get a hold of you, or if they wanted to seek your consulting services? Is that sort of a hard ordeal, or what does that look like?
No, that's pretty easy to do. You can go to Cambridge Sport and Spine and look me up. It's cambridgesportandspine.com, or you can go to email me at cambridgesportandspine@gmail.com, or you can find me on Stu's website, Backfitpro, and it'll link to that contact information that I just gave. And that's probably the easiest way to find me.
Okay, great. So we'll put all that information in the show notes about Ed, and check him out. Check out Backfitpro, and I think there's a lot of great thinking in this episode, really about like, hey, if you're looking at these online, fitness professionals and people are offering advice, just think about sort of what works for you in your situation, and really need to take that tailored approach. So thank you again, Ed, for making time on a Monday evening. I'm sure you have better things to do, but appreciate you talking to me today.
No, thank you, Rupesh, and I enjoyed the talk and the interview. It was fantastic and masterfully done. So thanks for taking a rookie and making it very easy for me. So thank you, and best of luck. I think I got to figure out where I can tune into your podcasts.
You bet. All right, everyone. We'll wait for a couple more weeks and we'll got another episode. So talk to you all later. Thanks, everyone. Bye.